Okay, everybody, welcome. Welcome to our event. My name is Daniel Canstrom, and as a professor here at BC and as the faculty director of the Rappaport Center for Law and Public Policy, it is my great pleasure to welcome you to this event on behalf of myself, on behalf of our wonderful and still new executive director, Amanda Teo, our fabulous assistant, Abby Chingo. We're also most grateful to our former, beloved, and already much missed executive director, Lissy Medvedow, for her work in organizing this particular program and innumerable other things that she did of greatness. So welcome back. This summer, I sat on my front porch on a sunny morning with a cup of coffee to enjoy an increasingly anachronistic, but for me still enjoyable and reassuring daily ritual, reading two newspapers. For students, I assume you still know what they are, but I know that it's not that common anymore. The New York Times and the Boston Globe. In the Globe, I encountered something that I found to be extremely moving. An op-ed that was penned by an esteemed BC Law alumna, Lauren Stiller-Rickley. It was quite provocatively entitled, quote, "The Hellscape of the Emergency Department." I highly recommend it in its entirety. It's not long. But let me just quote from it in part so you can get a sense of it. Quote, "While experiencing the interminable misery that is the emergency department at a premier Boston hospital, my husband and I saw a statement from its CEO touting the hospital's recognition by U.S. News and World Report as one of the best in the nation. We wondered whether she has ever spent time in the hell that is her emergency department. A young girl," oh, I'm sorry, you're already eating, but just so, trigger warning. "A young girl who arrived 8 hours earlier lay on the floor vomiting. An older man with a dangerous medical condition, there was no privacy, was sent by a community facility in another state, starting a new wait in increasing discomfort. Several people moaned loudly, others sobbed. One paced while swearing about his predicament. The bathrooms were constantly full. An inebriated man, teetering and incoherent, wandered the ED without attention, coming dangerously close to falling into the laps of crammed patients. A couple watched a violent movie at full volume on their phone, never asked by staff to lower the overpowering sound. Scant attention was paid to the man bellowing at an elderly woman, nor to another woman repeatedly shouting at someone to shut up." End quote. So my personal reaction to this was, to say the least, complicated. On the one hand, I too have had some rather disturbing ER experiences in my life, though nothing quite like this. So I confess I was personally inspired to eat better, drink less, stay off ladders, and work out more regularly. On the other hand, though, I felt somewhat useless, as this is not an arena in which I have expertise, and I was quite uncertain about how law and policy, or indeed we the people, should deal with these problems. I was reminded of the old apocryphal story of the British academic who, upon learning of Hitler's invasion of Belgium, said he had half a mind to write a stirring letter to the London Times in strong opposition to such things. Fortunately, we at the Rappaport Center can do a bit better than that, and when I suggested to our board that we examine ER care in Massachusetts, the response was enthusiastic, especially from one board member with real expertise, Mary Beckman, who quickly volunteered to take the lead and help us to organize the excellent program with speakers that we have for you today. So let me heartily thank those speakers. They're going to talk about some really difficult, intractable problems of law and public policy, and I'm very grateful for them for being willing to do it with us. And also especially thank Mary and our wonderful advisory board members as I briefly introduce Mary to you. She in turn will introduce the speakers and moderate what I'm sure will be a fascinating and challenging discussion, followed by Q&A. Please do note that this event is being recorded. Mary Beckman is the former acting secretary of the Massachusetts Executive Office of Health and Human Services. She was previously chief of Healthcare and Fair Competition Bureau in the Mass AG's office, overseeing the nonprofit organizations and public charities, Healthcare, Antitrust, Medicare Fraud, and False Claims Division. She previously led the nonprofit organization's Public Charities Division, which oversees public charities, including nonprofit hospitals and health insurers in Massachusetts. And she served as an advisor during the drafting of the first restatement of the law of charitable nonprofit organizations, and has taught nonprofit organization law at New England Law School. Previously, she was the Chief Compliance Officer at Boston Children's Hospital and served the Commonwealth as the Assistant Secretary for Health Policy. And she has also served as Deputy Legal Counsel to Governors William Weld and Paul Cellucci. So let me turn it over to her capable hands, and let's just welcome our speakers for today. Thank you all for coming once again.
Thank you, Professor Kingston, and welcome everyone. Very glad to have you all here, whether you're here in person or online. We've already had an introduction to the topic, but I'm just going to say a few more words about it. I was going to start by saying very few of us have no experience with the ED crisis, either personally or with a family member, but then I was reminded that the demographic of the law school might lead to a conclusion that that's not necessarily true, because most of you are young, but trust me, most families do have some experience of an emergency department here in the Commonwealth and across the country. I think this is a problem that would at least reflect some of the elements that were in the editorial that you heard from earlier. Waiting for care and attention in the emergency department can take hours, and ironically, sometimes if you're not obviously in an extreme situation, it can take even longer. Conditions in the emergency department can be challenging. There's overcrowding, families with fussy children, people with symptoms that those of us that are not medically trained would say seem alarmingly contagious, sitting right next to yourself, your family member, someone who might be immunocompromised, and others who may be vulnerable and in distress, sometimes in mental health crisis for hours. And also, while rare, there have been some bad outcomes that those of you who've been following this might have read about in the paper the last couple of years. That's where conditions in the ED were at least speculated to be contributing factors. Some people have raised questions about whether hospital and emergency department operations and operational decisions contribute to some of these conditions. But it's also a manifestation of larger problems in our healthcare system and in our social support system at large. Unlike other healthcare providers, hospital emergency departments, as you might know, are obliged to screen and stabilize everyone who appears for care at the ED. In addition, hospitals must ensure that inpatients have a safe and appropriate discharge plan before they discharge the patient. There are a number of reasons why patients who no longer need inpatient level of care face obstacles in moving to the next appropriate level. Some of those might be administrative, many of them are psychosocial, but we'll talk about some of those today. But in short, the ED front door is open to everyone, and the back door tends to get clogged, whether it's clogged from moving out of the ED to the next appropriate setting, or whether it's because you need an inpatient bed and those inpatient beds are clogged for the reasons that I just alluded to. That combination leads to the crisis that we're talking about today. We are honored to have a panel of truly distinguished experts who will help us unpack this issue, understand some of the contributing factors, and hopefully help us discern some possible ways forward that might help alleviate some of the problem. I'm going to introduce the panelists next. Amy Hoey is the president of Lowell General Hospital, which is a part of Tufts Medicine. She's the first nurse to serve in the position of president, and her prior roles include serving as Lowell General's chief operating officer and chief nursing officer. Lowell General operates one of the busiest ERs in the Commonwealth. Dr. Guy Fish is the CEO of Codman Square Health Center, and prior to that was the CEO at the Greater Lawrence Family Health Center, both federally qualified community health centers. His prior roles include leadership of biotech companies and providing direct health care to community members in his native Ohio, in Delaware, and in Massachusetts. Among other nonprofit leadership roles, Dr. Fish is a founding member of the Massachusetts Health Equity Compact. Dr. Ashley Yeats is the Vice President of Medical Operations at Blue Cross Blue Shield in Massachusetts, where he focuses on a number of areas of operations, including medical policy administration and clinical appeals. Dr. Yeats has practiced in the Boston area for 20 years, and some of his prior roles include leadership positions at Beth Israel Deaconess, including Chief Medical Officer and Associate Chief of Emergency Medicine at BI Deaconess Milton Hospital. And Dr. Robbie Goldstein is the Commissioner of the Massachusetts Department of Public Health. DPH includes over 3,000 employees working on various aspects of public health, from maternal and child health, infectious disease, environmental health, and a lot of other areas, and notably including the regulation and oversight of healthcare providers and healthcare quality. Dr. Goldstein's prior roles include Senior Policy Advisor at the Federal Centers for Disease Control and Prevention and clinical leadership roles at Massachusetts General Hospital. Each panelist is going to speak for a few minutes about his or her perspective on the problem that we're discussing today. Then I'm going to pose some questions for discussion, and then after that we will turn to questions from the audience, whether from those of you here today, in person, or online. So with that, I am going to turn it over to Amy Hoey, who's going to kick us off.
Great, thanks Mary. Good afternoon everyone. It's such a pleasure to be here with all of you and with this great panel to talk about this incredibly important topic. Sorry, my microphone wasn't on. Incredibly important topic. It's something that's near and dear to my heart as a hospital leader in a community where I live and work. We're all concerned about the same things. We want patients and families to receive timely, high-quality care in the most appropriate setting for their clinical needs. And the challenges that exist in emergency departments are really a symptom of challenges across the whole healthcare continuum. All of that really displays itself most acutely in our EDs, where the doors don't close, as Mary said, and we don't have the ability to constrict our census based on presenting volume. So I'm going to share just a little flavor of what's going on at Lowell General Hospital. It's an example of what's going on at hospitals across the state and across the country, and then share a few examples of some innovations that we have been working very hard to put in place over many years to alleviate this problem. And what strikes me as we sit here today talking about this, I've been the Chief Operating Officer and President of my hospital for a number of years, really concerned about really focusing on this problem. And it's never been worse than it is today. And so that's stunning when you sit back and think about it, how something that we all care about so deeply and we've been really focused on improving can continue to deteriorate. So just to give some numbers, and the numbers specifically aren't important, but they paint the picture. So our emergency department sees about 85,000 patients a year. People say, well, what about urgent care? Well, we have 4 urgent cares in the communities surrounding our hospital that we own, and they see about 75,000 patients per year. And today, as we're sitting here having this conversation, there are at least 27 patients, boarding patients, holding in our emergency department waiting for an inpatient bed upstairs. And that's never a reflection of the inefficiency of an emergency department. It's really a reflection of the inefficiency of the healthcare system and the funnel that brings patients to our emergency department, and then our ability to outflow patients out of the emergency department. And so when we think about patients that are presenting to the ED, limiting the number of patients to those which truly need to be in an emergency department is important, and that's challenging. Access to primary care, as many of you know, is a significant problem. There are patients that don't have the ability to seek a primary care physician for insurance or other reasons. There are many factors that influence patients that are presented on the front end. And then on the discharge side, Mary alluded to a lot of the factors that limit the outflow of patients. So the numbers that we focus on beyond those holding patients is our left without being seen rate. We care very much about patients that present to the emergency department and register and leave without seeing a clinician. And that number at our and all hospitals should be less than 4%. But when we get under extreme holding and boarding pressure, it can rise into the teens, where 15, 16, 17% of patients presenting for care register and leave before seeing a clinician. And you hope that those are lower acuity patients that didn't necessarily need to be seen that day, but we know there's other patients that really do need to see a clinician. And then on the outflow side, the number that I really think about is our discharges. So at my hospital, if we don't have 60 to 70 discharges per day, I know that we are going to start to get into a boarding problem just because of natural throughput. And what is it that limits those discharges? It's not factors that are in the direct control of the hospital. It's things like availability of skilled nursing at home, availability of SNF beds in the community, patients waiting for guardianship, patients that need to go to an LTAC facility or state hospital. And so as the number of stuck patients, as we call it, begins to build, we know we're going to have problems on the front end. So these are typical problems that every single hospital experiences, and we've worked really hard to invest in creative solutions to try to make that better. So what are some of those investments that we've made? We have an inbound coordinator. So I talked about the front end of patients presenting to the emergency department and trying to make sure we're dispositioning them to the most appropriate level of care. So our inbound coordinator can help by engaging with primary care physicians who say, I have a patient that might not necessarily need to come to the emergency department, but they need a care need that the PCP can't meet. Maybe they need IV hydration, perhaps they need a follow-up visit at home the next day. So our inbound coordinator can help work with the primary care physician to keep that patient from presenting to the ED. Oftentimes, one of the resources we use to prevent that ED hospital admission or that ED visit is mobile integrated health. So we're very fortunate at Lowell General to have our own in-house paramedic program, but other hospitals that don't have their own internal program partner with private ambulance companies for something that we call mobile integrated health. And it's different than the visiting nurses that you would think of more traditionally, who have a more longitudinal relationship with the patient. Mobile integrated health paramedics can go to a patient's home for a single episodic visit under medical direction from one of our physicians, and they can provide a liter of IV hydration. They can follow up on an ED visit from yesterday so that the patient didn't have to be admitted. So MIH is another really important tool that we've used. And the last one that I'll highlight is transportation, right? So this is a problem of many, many factors, both on the front end and on the back end. And some of the things that aren't as obvious to all of us is something like transportation. Getting an outbound ambulance to take a patient to a behavioral health facility can be extremely challenging. Private ambulance companies, they have their own staffing challenges. They have staff out with viral flu and illness, and they want those quicker local transports that are part of the backbone of their business. And oftentimes the behavioral health transports are longer lead times. They're to facilities that are farther away. They're for uninsured or underinsured patients. So they're less attractive to the transportation companies. So one of the other strategies that we've invested in is our own transportation ambulance for behavioral health. So we partnered with the state to come up with a model that met all the regulatory requirements, where when we have a behavioral health bed for one of our patients, we can take them there ourselves, and we don't have to lose that bed because we weren't able to get the patient there due to transportation needs. So those are just a few examples of some of the innovative solutions that we've tried to put in place. Funding for those innovative solutions is another conversation that we'll get to, because that's also an issue. But I just wanted to give a flavor of some of what the hospitals and health systems are experiencing as we're working very hard to reduce not only wait times, but certainly boarding, and make sure that our patients are receiving the right care in the right location without all those inefficiencies. Mary?
Thanks so much. We're going to go to Dr. Fish.
Good afternoon, everybody. Hope you're all well and warm. I'm Guy Fish, and I am going to elaborate a little more on CEO Hoey's comments with respect to the front end. So when I think about healthcare in this country, I always keep in mind two things. Very famously, many years ago, when I was about your age, someone said, "This is America. If you want to know what's happening, follow the money." Look up that reference. It's very germane to these days now. The second is you get what you pay for. All right, so keep those two things in mind. So again, as Amy was describing, you can think of what's happening with respect to patients in the emergency department as being part of a continuum of supply and demand. And there's a big demand, and for a service model, not a product, but a service model, the question is, how big does the supply need to be to service that demand, right? And right now we have a mismatch. And so part of that mismatch has to do with things that in that passageway from wanting and needing care to being serviced completely. In that continuum, there are things that gum up the system and slow down the flow, like prior authorizations and other things that my colleagues will be talking about. But I'm going to focus most of my attention on what's at the front end. Why is the demand so high? And what are alternative ways of reducing that demand? Because if you reduce the demand, then maybe the pipe through the hospital is big enough, right? Maybe you don't need 67 discharges a day. Maybe 50 is okay, right? So again, in this country, we're very heterogeneous. We have people from all over the world who come here. One of the things that I see at my health center in Dorchester, where 35% of my community is Haitian American, about 10-12% is Vietnamese American. There are people who come here from other countries where the norm in those countries is if you get sick, you go to the emergency department, period, full stop. That's the first thing that you do. And so if they are arrived in America and get sick, they're going to do what they know to do, right? So there is a part of acculturating new members in our society to how this works, and that they really should establish a longitudinal relationship with a primary care physician. We'll get back to the primary care physician relationship in a second, but let me go on to say that another significant problem Amy's already addressed, which is behavioral health. We know that in emergency departments, up to 40% of people who present there have a concomitant behavioral health issue that is either the primary problem or exacerbating whatever they presented for. And sometimes if you can get that taken care of straight away, maybe the need isn't so emergent, maybe it's more urgent and they can be seen elsewhere. But it conflates things and it gets in the way of being able to in one location called an emergency department, handle all of that and more. Now, the key thing that I really want to focus on is the supply-demand function with respect to primary care. And in the United States of America, we've got wonderful academic medical centers. I've been on the boards of several of them. I've been in charge of committees on several of them. They're fantastic. If you get sick anywhere in the world, odds are you want to come to the United States and probably to Boston to get treated, because we do have like a medical mecca here. But for 95% of us, 95% of the time, we really don't need specialty care at the tertiary and quaternary level of medical care. We need primary care, someone to help us figure out how to keep our blood pressure under control, and lose a little weight, and maybe get us through a bout of depression. The problem is that only 5 cents of the American dollar spent on healthcare goes into primary care. You get what you pay for, okay? Second problem is that the way that primary care is reimbursed is through what's been traditionally a fee-for-service mechanism. That's moving towards something else called capitation or value-based care, but still a large percentage of care is delivered under fee-for-service, and the physicians who are treating these patients have been schooled to operate under a model that says the more patients you see, the faster you go, which reaches a limit, right? Just mathematically, there's a limit. You got to spend at least a minute with a patient. So the more you see, the faster you go, the more you get paid, and that's just a hamster on a wheel. So what ends up happening is that we have a limited capacity to see patients in primary care, and we need to move away from that model and get into other models that allow us to treat the patient with a dignified amount of time. The last thing that I'll say that's driving demand is that, here's a statistic for you, 80% of healthcare, by many, many different studies, it averages out to about, people say about 80% of health, being healthy. It has nothing to do with the doctor seeing a patient. It has to do with what we call social determinants of health, which I can't say anymore because that's on the banned word list apparently, so it's got to be called health-related social needs. But if you really haven't eaten in 3 days, you don't have a roof over your head, you don't have transportation to get to a job or to get to your medical appointment, these are things that make staying healthy really difficult. And again, we're not paying for that. We're not paying for wellness. Dr. Goldstein, Commissioner Goldstein, is sitting to my left here, and he thinks this way in terms of being able to address those sorts of things, but he's got an uphill battle. So in the meantime, community health centers, which I'm now on my second one running, have a major role in doing exactly that. Organizing resources, not stealing, but begging and borrowing money from foundations and other philanthropies and grants to begin to address the social determinants of health that reduces the degree of sickness that's out there, that reduces the need for people to go to an emergency department to get their care. So we have plenty of work to do on the front end to reduce care. We know what the issues are. We need to change the financing system in America for how healthcare is paid and increase the amount of dollars that are going into primary care as well. I'll stop there.
Thank you so much.
So I'll pick up. So I'm actually Yeats. I'm an emergency physician by background, spent 25 years in the emergency department. I want to just pick up on some of the themes we've heard here. You heard Guy reference the concept of demand capacity matching. IHI's done a lot of work in this space, and you heard Amy talking about the inflow and the outflow, what's coming into the emergency department versus what's coming out of the emergency department. And when I think about this, I think about what is a tremendously complex system of care. And a system is made up of multiple interlinked processes. And in these processes, you've heard about primary care appointments, you've heard about the absence of those appointments and patients being diverted to the emergency department. You've heard about discharges and touched on prior authorization, which we'll talk about in a little bit. There are many, many other contributors to the hospital capacity. When I was working in the emergency department at my prior hospital, we had 19 ED beds at the time. This was a time when putting patients in hallways, it happened, but it was not the norm all the time. I think Amy and I were talking prior to the talk, she's talking about having to access 50 hallway beds on any given day. If we talked about 2 patients in a hallway in my hospital 10 years ago, that would be dramatic. And what's happened is this system of care has got stressed now to a point where it is operating beyond capacity. And when you look at how systems work, there's something called queuing theory, which means that you have to keep that system at about 85% capacity in order for everything to be able to flow through smoothly and to be able to accommodate those ebbs and those flows in the system. We've been operating at over 100% capacity for a long time, back prior to COVID. My own hospital saw the closure of Quincy Hospital, right? And we recently seen the next most adjacent hospital to VID Milton, the closure of Kearney Hospital. And so we're scrambling to dig out from under these headwinds by opening urgent cares, right? Another, Amy talked about before, urgent cares that her hospital operates, my hospital operates one in Quincy as well, but we've never been able to get, we've been digging out, we've never been able to get out from below the water to even start to get back to being operating at 85% efficiency. We also know in these complex systems of care that when you optimize one process, it comes at the expense of another process. You really got to have that whole value stream in your mind as you think about interventions. Otherwise, you're going to intervene on one element of the chain, but if all that you do is optimize that and you bump up against the next blocker in the chain, you haven't really improved the input to the output. When I was also in hospital administration as the chief medical officer, when we saw the emergency department getting blocked, so if on a Monday morning I saw 3 behavioral health orders in that emergency department of 19 beds, I knew we were going to be on code health by 2 o'clock in the afternoon at the latest, because those 3 beds were designed to flip 6 to 8 times in a 24-hour period. Right? And when they're being blocked by somebody who's residing in that bed as if they were a hospital inpatient, you're preventing the access to that bed for 6 or 8 other people who are in the emergency department, and you start to see these complications that were alluded to in that article. So one of the levers that I could pull is I could cancel elective surgeries in the hospital. There are patients going to inpatient beds that aren't getting to that bed via the emergency department. But when I do that, I'm doing a number of things. I'm cutting off an income stream to an entire group of physicians on the medical staff. I'm cutting off care to patients who have not had an emergency, but have a medical need that needs to be attended to. It can be scheduled. It's not urgent, drop everything. You're doing that, but you're also cutting off in this fee-for-service system that Guy was alluding to. You're cutting off the the service lines within the hospital that actually drive at the margin, that fund those services within the hospital that lose money. Inpatient medical care generally does not generate the revenue that it takes to fund the services that are being provided. And so those services are funded by this fee-for-service system of high-margin service lines like total joint replacement or bariatric surgery or some imaging services. So there's a lot, as we're thinking about solving this problem, there's an overwhelming number of pieces to the equation. Guy touched on social factors, patients who come to the healthcare system maybe with a different cultural background, but also we live in an on-demand system. I want what I want now, and generally I want it delivered if possible, right? I want it delivered with a high degree of service. And our lives have become very, very complicated. So if you can't get an appointment with a PCP today or 3 days from now, or you're in a social situation where you can't take the time off work to get care during regular business hours, where are you going to land? You're going to land in urgent cares or emergency departments to receive that care. We talked about some of the blockers on the outflow side, right? The access to a skilled nursing facility bed. Could be the raw number of beds available, could be illness, right? Influenza is going through our community right now. When influenza goes through the community, it goes through our healthcare providers as well. So does Amy have the staff and her hospital and nursing staff to staff the beds that she's got? Does the skilled nursing facility have 30 beds but only staff enough for 15? So lots of sort of complicated pieces to this. The doctor's going around the hospital in the morning. You know, ideally, if you're not on the path of discharging somebody by 9, 10 o'clock in the morning, the chance of you being able to effectuate that discharge at 3 o'clock in the afternoon become increasingly more difficult. So some of these patients, they can go home, but maybe not until after they've had their echocardiogram. The echocardiogram is an outpatient test and an inpatient test, and they're scheduled for that echocardiogram at 5:45 in the evening. How do you get a patient from a hospital bed to a skilled nursing facility at 6 or 7 o'clock in the evening when they downsize their staff? So all of this queuing theory and complicated pieces to it. I sit in my role now as the Vice President of Medical Operations at Blue Cross Blue Shield. You know, we certainly don't want to be in the way of getting our members, the physicians, patients, you, to the care that you need. In 2024, we dropped prior authorization criteria for home care so that the staff in the hospital know that if a Blue Cross patient is going to need home care services, those home care services are going to be covered. You don't have to get permission in advance for those services. We'll review the necessity of them days later, or maybe even longer than that, a week to 10 days later, to see whether they're still necessary. And we need to start to involve our case managers at the plan to tee the family up for success to be able to manage this care without the skilled services that are going into the home, the physical therapists, the occupational therapists, the nurses, whatever that care need might be. We don't require prior authorization to move a patient from a hospital emergency department to a mental health hospital. We call this notification only. We just need to be told within 48 hours that the patient is admitted. And the same is true for the inpatient admissions that go through the emergency department. We recognize that access to skilled nursing facilities and rehab hospitals, long-term acute care hospitals, maybe where somebody's on a ventilator and has a very highly skilled need. There is prior authorization required for that because we see, and we saw this during the pandemic, that when through interventions during the pandemic to really move patients through the system included lifting those prior authorization criteria for rehab hospitals, for example, we saw people landing in rehab hospitals who were not ideally suited for the intensity of the service at the rehab hospital. We saw patients that would have been more appropriately cared for in a lower skilled facility at lower cost, landing in rehab hospitals, being there for a day and realizing that this level of service wasn't appropriate. And then the request would start to come in to then transfer them from the rehab hospital to the skilled nursing facility. Generally speaking, we don't do that. If the patients got to the rehab hospital, we'll keep them there until they're well enough to go home, because it just does not make sense to add more complexity to the system by having patients hop from facility to facility. And we get into then preference-based care versus evidence-based care, right? And that preference can be from a provider, but that preference can be from a family. As a physician, you can imagine somebody might want their loved one with a stroke to be at the rehab hospital and not at the skilled nursing facility. And it was certainly easier, perhaps, for me as a physician to say the insurance company won't pay for this, than to really get into the much more longer and complex conversation about, unfortunately, the degree of disability that your loved one has had from the stroke means that they can't participate in the intensity of services at a rehab hospital. And that's delivering a really hard message, right? It's a heartbreaking conversation. Doesn't mean that they may not progress after several days or a week or two at the skilled nursing facility and be able to bump up to that next level. And in that preference-based care category, we have patients, in one of the most stressful moments of their life with their family showing up on the medical floor, say at your hospital, and being asked that question, what skilled nursing facility do you want to go to? And oh, by the way, we think you're going to be here exactly 1.7 days, so you need to make this decision now, and then research all of this, and get back to us, and then let us know, and then we're going to check and see whether that bed is available at that skilled nursing facility. And then we're going to get the prior authorization for you to get there. We have at Blue Cross optimized to the best of our ability our approvals for skilled nursing facilities. Generally, we turn those around within 2 hours of receiving them. But we know that that's not always the case. Things do get backed up. Some requests get more complicated. Sometimes the information's not there to make the decision. Sometimes the requests coming in, and really everybody but the family knows that this request for rehab doesn't meet the criteria, but they're going to try anyway, and so we're then having to say no. And it takes us a little longer to say no than it does to say yes, and where that patient sits on the floor at the hospital and sort of adds to that feeling problem. So I'll stop there, but all of this to say that it's a really complicated problem to solve, right? And if it had been easy, we would have solved it a long time ago. But not only has it got more complicated, the system has got more stressed and has become more desperate. And these targeted interventions like the mobile integrated health or my hospital opening up an urgent care center aren't enough to unclog the whole system. They definitely make improvements, but we're making little incremental improvements, and sometimes it's whack-a-mole, sometimes it's systemic improvement.
Great. I'll jump in. Good afternoon, everyone. Robbie Goldstein, the Commissioner at the Department of Public Health. I think before I kind of launch into my story, which is going to be about regulation and government bureaucracy, I want to remind folks I'm actually a clinician. Not just a regulator. 2 years ago, I was floating through the emergency room at Mass General Hospital as the ID consultant. And I think what you're hearing from folks here is that if you look under the lamppost when you're sitting in the emergency room, you can see the chaos and you can feel that constant inflow and the inability to have outflow. And when you're in it, it is really challenging. But we have to zoom out. We have to take a much broader look at this and look at the whole continuum of healthcare. And that's what the Department of Public Health strives to do. We don't always do it as well as we can, but I think we're trying really hard to think about how our regulation and how our policies can impact all aspects of the continuum of healthcare. So I thought what might be helpful is if I talk to you about some of the tools, some of the levers that we have in regulation and government policy that we're using to try to address the capacity issues in the emergency room. It might stimulate some questions, help you think about other areas that we should look at, other ways that we could address this issue. I want to start with where we've all sort of started, which is in the primary care space. The fact that so much of what we see in the emergency room could be managed in the primary care setting. But if we think about it, here in Massachusetts, we have the highest rate of insurance coverage of anywhere in the country. We have over 90% of people in the Commonwealth have a primary care doctor, but we have fewer primary care doctors per capita than any other state. We don't have enough of a workforce to take care of the people, and that means that even though 90% of people have someone listed as their primary care provider, they can't get the appointment. And so there are things that government can do to try to address this. We are trying to work on improving the primary care workforce. So that looks like bringing in more people. We do that through our J-1 visa program, trying to encourage folks to come into this state, come from other countries, work in primary care, work in under-resourced settings. A law was just passed at the end of 2024 that we're implementing this year to bring in foreign medical grads and to give them a pathway to licensure and certification here in Massachusetts without having to go through a residency program. We'll expand the number of primary care docs that we might have here. We're also thinking about scopes of practice. How do we encourage nurse practitioners and physician assistants to come in and provide that primary care? And can we use the regulation that governs those professions to give them the freedom and the flexibility that they need and also maintain safety and quality of care in the primary care setting? So there are a lot of tools at our disposal, and we're using all of them, and each of them are chipping away just a little bit at this primary care access. If we look at urgent care, sort of the next step in the continuum, really no two urgent care centers are the same in the Commonwealth, and that is sort of a reflection of communities. Every community needs something different. Every urgent care can provide something different for that community, but also actually the lack of regulation that exists in the urgent care setting. Because of that lack of regulation, some urgent care settings, maybe those that are affiliated with a community health center, maybe those affiliated with a hospital, have certain staffing levels, they have certain requirements on what insurance they would take, and others, a lot of the private for-profit urgent care centers, don't have to meet those. And that means they might not take someone with a particular insurance, or they might not be able to provide the service that is necessary, and you end up having to shift to a higher level. So the department is, through statutory authority, now moving forward with the process of licensing all urgent care centers in the Commonwealth and making sure that through regulation we have some consistency to maintain quality and safety, but also we hope that this will improve access to the urgent care. It'll make sure that people can actually get the services they need when they walk in the door. As part of that work, we think about the behavioral health urgent care setting, and the state has pushed a lot of resources into building out community behavioral health centers, which are basically urgent care centers for behavioral health needs, making sure that there's a 24/7 location for someone in crisis to go to. We've done a lot in collaboration with Mass Health to make these accessible, affordable, in the communities where people need them and connect them to the broader mental health care settings. But there's a lot of work that still needs to be done, both through our regulatory action, but also I think in working with the community health centers, working with the hospitals to better utilize the community behavioral health centers. In the emergency room itself, we have regulatory jurisdiction, although I'm actually going to skip the emergency room because it is, while it's the topic of today's discussion, it is actually not the problem, I think. The problem is outside of it. But it's the act of getting to the emergency room and then leaving the emergency room where I think the department has a lot of regulatory authority and some control. And by that I mean we house the Office of Emergency Medical Services, so the paramedics, the EMTs, the ambulances, all of those services across the Commonwealth report into the department. And we are thinking a lot about what can a paramedic do in the community. We heard earlier from Amy about mobile integrated health. What is the scope of mobile integrated health? What are the other ways that we can use paramedics and others in that care continuum, EMTs and other folks, to deliver care in the community and either prevent the transport from the community setting to the hospital, or perhaps get folks out of the emergency room and then to the next level? How do we try to increase that flow through the system, recognizing some people are going to have to go to the emergency room, but can we get them out of the emergency room rather quickly with additional supports? And then the last part of the continuum that I'll talk about is once you leave the emergency room, and if the decision is you do need to be admitted to the hospital, or to go to a post-acute care setting, what can we do as the department to try to increase that flow out? And we have, since COVID, since I believe 2021, had a memo that has been continuously active and renewed that has allowed hospitals to surge their license space. So all hospitals have a certain number of beds that are on their hospital license. Those beds meet certain criteria to make sure we can maintain quality and safety standards. And yet, as emergency rooms get busier and busier and busier, as more and more folks are being admitted to a hospital, there is a need for more and more beds. You can't just build a bed overnight. It's really hard to do that work. And so we've allowed for surge capacity in hospitals through our regulatory authority. And we have to figure out what to do with that. We have some hospitals that are operating at 150% of their licensed capacity because they are using as much surge space as possible. When I say surge space, sometimes that's a hospital bed that was sitting empty because it wasn't staffed for some reason, or it was an older wing of the hospital and wasn't being used. But sometimes we're talking about a hallway on an inpatient unit. We're talking about a family room or a conference room that was on the floor that now has a bed in it and some sort of monitoring system. And so these are not what we anticipated to use for healthcare delivery in a hospital. And it is the department's responsibility to think critically about how we best use those resources within the hospital and beyond, right? The same constraints are happening in the post-acute care setting. And we think with the skilled nursing facilities, about the rehab hospitals, about using their beds appropriately, using their space appropriately to take as many patients and to do it safely, to do it with the highest quality standards. So we are at the department looking throughout that entire continuum, trying to use the tools at our disposal, which are largely regulatory tools, quality and safety standard tools, to make sure that we maintain the care that folks in Massachusetts expect, but also are trying to alleviate all of these bottlenecks that occur along the continuum.
Well, thank you. This is clearly a very complex, I'd say problem, but it's more than that. It's a manifestation of just a whole lot of challenges across our societal continuum. Difficult to know where to take it, but I'm just going to throw a few questions to some of our panelists for more discussion. One thing that I'm not sure if it's come up here, but it has come up in discussions over the last year or two, is that patients presenting to the emergency department these days, it's been said, are sicker than they were pre-COVID, and they are requiring inpatient hospital stays that are longer. And I'm wondering if our clinicians here could comment on that. Is this because at first after the pandemic, we thought, some of us non-clinicians thought, well, there was a lot of deferred care during the COVID lockdown, and maybe this is a catch-up kind of situation. But it's now been a few years. Do you think this is a catch-up situation, or is it a new phenomenon that we're going to have to deal with?
I'll jump in. I'm not sure I'm the right first person to jump in, because all full disclosure, it's been 5 years since I saw patients. It's been 5 years since I saw patients in the emergency department. But I think there's a couple of things. I think as our system of care falls apart in the primary care space, in the mental health space, in the preventative care space, people don't get those upstream interventions that keep them well. And so I think we're seeing that. I think we're seeing the impacts of technology and science, right? There are drugs that have been released in the last several years that have the ability to cure sickle cell disease. This is just incredible tip of the spear medicine, precision therapies. They're very expensive. And in the other end of that spectrum, we're keeping people alive with drugs that when I was trained in the 80s and 90s in medical school would not be alive today. And you get to sort of see them, move and become older and stay well longer. But eventually things do start to unravel, and I wonder if that's an element of this in terms of people being sicker. You can hypothesize that the financial and social barriers to accessing care might lead patients to seek care when they are sicker because they're balancing two jobs, so they're waiting it out, so they don't have the money to spend on what they perceive to be elective care, and so the wheels fall off the cart and it becomes urgent, and they land in the emergency department. Those are things that come to my mind. When I think about this, you see the sick patients every day, Guy, you see them in the clinic.
And I think the COVID catch-up was more on, mammograms and colonoscopies and that type of deferred care, but the acuity of the patients that we're seeing today, the severity of illness of the patients that we're seeing is very real, and there's lots of data points that prove that out. We have something that's called the case mix index, which tells you about the relative illness of the patients in your hospital, and it continues to increase. And so I think that that's very true. A lot of times in the past, talking about ED boarding and overcrowding, people in the healthcare system would say, well, we shouldn't have those soft admissions. And there was this idea that there were patients that were admitted to the hospital with fairly low acuity illness that could have been cared for in a different setting. And that's really gone away. There are very few instances where there are patients that don't need to be in the hospital. The problem is the outflow and making sure the minute they don't need to be in the hospital anymore, they have a safe place to go to continue their care, and to make sure that the overall funnel and volume of patients generally coming to the emergency department gets addressed.
I'll give you a little snapshot about, let's say, a year in the life of a Boston resident, okay? 02124, it's Dorchester, one of the oldest communities in Boston, right? It's gone through its transitions from being, largely Jewish, largely Irish, to now African American, and now Haitian. But as that happens, several things are happening simultaneously. I'll speak to gentrification. I'll speak to closure of primary care practices, and I'll speak to immigration. So gentrification, Codman Square Health Center has a fairly significant cadre of patients who have been gentrified out of their community. They have moved for economic reasons to Randolph, which is 10 minutes south of Codman Square. It takes 20 minutes by car. It takes an hour and a half by public transportation. And they're still my patients. They still say, Dr. Jones is my doctor, and I need to get to see him or her. All right, well, an hour and a half to get there, an hour and a half to get back. You've lost a day at work, right? Or maybe it's your kid, you got to pick them up from school and then take the buses, right? So gentrification is something that is happening on a societal level and is causing a rupture in the ability of patients to see their doctors. Second thing that I mentioned, which was
Closure of primary.
closure of primary. Thank you so much. We've all heard about the Steward Hospital System meltdown. Kearney Hospital was 0.8 miles from my health center. A lot of the patients that were seeing doctors at the Kearney system for primary or secondary or tertiary care, they're not there anymore. Before that, there was Compass Medical System. They shut down, right? So we're seeing this retraction of the availability of care. And so again, if you can't get there because of transportation, or there's no place to get to because they've closed down, how often are you going to get your care? Not that often. When you do show up, how well are you? You're worse off. Third thing is immigration. We have seen a 16 to 20% spike in no-shows and cancellations in our clinics. And when we call up people and ask them why, again, very heavily immigrant community, they're saying, I'm afraid that if I show up, ICE is going to be there, right? Which is not good. And so when they do show up, they're sicker. So we have a whole set of things that are happening in the year of the life of a 02124 resident that compound and delay care, and so when they do show up, they are sicker.
Just had one brief point to this, which I think all of this is true and is explaining why we're seeing increased acuity in hospitals. I think we also can't miss the demographic shifts that are happening in Massachusetts, in particular the graying of the population, right? The aging of our population. I actually think we're on the front end of that, and so we should be expecting to see older and sort of by definition sicker, more complicated individuals showing up to the hospitals, right? It's very different for, I'll use myself, a 41-year-old to have pneumonia than it is to have an 81-year-old with pneumonia, right? The 41-year-old likely has no other medical conditions, can probably be treated as an outpatient with oral antibiotics. The 81-year-old is on multiple medications, requires complex evaluation and monitoring to make sure that the antibiotics are not going to interfere with any of those, and is unfortunately likely to tip into some other complication while they're sitting in the hospital, which requires a longer stay, more complicated treatment. So that aging of the population that we are just starting to see is going to complicate this even further.
Thank you so much, everyone. It sounds like on that one, there's some aspects of that problem that are part of our future, like the very young population, I say nervously, being one of those. But there's some where we could do a better job of planning, making care more available in the community. I want to just throw something out that there's a concept called health planning that has sort of waxed and waned in popularity over the last, I think, at least 75 years in the country, where, the idea is the state or somebody with state imprimatur will sort of look at the population and project the health needs and plan where we should have different facilities. And it's an idea that I think is on the ascendancy a little bit with the legislation late last year. Do you have hope for that, or do you think in the past, I think there's been mixed reviews on the success or failure of that, maybe more successful when it comes to planning where a big hospital facility should go, less so on the primary care side. Any comments on that? It just came to mind from hearing your comments.
I'm happy to start, although I don't know if I've vetted these comments with the governor, so please go ahead. I do think that it's on the ascendancy. I think we saw in the most recent legislation that there had been a long-time plan for the Department of Public Health to hold some of this planning function, and it's shifting to the Health Policy Commission with consultation with the Department of Public Health and others in the healthcare space. I think planning is essential. We need it to understand where we're going, what we need to invest in. And getting back to what Guy said, we have to follow the money, right? We're going to get what we pay for. And so if we don't start directing the money in the right places, we're not going to see the services that we need. What I oftentimes worry with planning, there's two worries I have. One is that it's very much a snapshot in time. So we could do the planning today and tell you what is necessary in the Commonwealth, but 6 months from now, a new innovation could come along. A closure could happen of a big hospital system. Something could shift, a pandemic could happen that is going to change our planning needs. And so unless we're constantly reevaluating, that plan is just one snapshot in time. And the other fear I have with planning is that oftentimes we focus very much on the essential services, which is appropriate for planning to do, but we don't also take into account some of the additional services that are provided in the healthcare space. And therefore we allow that part of the healthcare market to grow unchecked. So an example is we don't oftentimes put dermatology practices or plastic surgery practices into planning, and yet we sort of allow them to grow and develop in a whole bunch of areas because they are profitable for hospitals and for health centers to open up. And I think for planning to actually be effective, it has to put constraints on both sides. We want to not see an expansion of only the things that are making profit at the harm of those things that are necessary and essential for our communities. I mean, that hasn't always been present. You've been around this longer than I have for this, but I don't think it's always been present in those conversations.
Certainly, there are economic incentives that work against that kind of comprehensive planning, and that can lead to an explosion in the amount of resources as a percentage of our whole that goes into healthcare, no doubt about that.
And I think, probably speaking to the macro level or the micro level, certainly the hospitals are charged with performing a community health needs assessment on a regular cadence. It was through that process that Milton has been, that hospital has been in Milton for, I think it's about 118, 119 years now. Its primary service area, it would say, was Milton and Hyde Park. But through the community health needs assessments around the time that the Quincy Hospital was closing, we realized that the community had changed. One of our primary service areas was Randolph, for all of the reasons that Guy described. We realized that 6 of the 10 Vietnamese-speaking physicians in the Commonwealth were on the staff at our hospital in Dorchester, but viewed BID Milton as its community hospital. And as a result of that, we placed a Vietnamese interpreter in the hospital daily to be able to help with the discharge planning and the care for these patients. So I think planning is important across the spectrum. I worry that with the stressors that have been on the system going back to the beginning of COVID, we're focused on the tyranny of the urgent and the fire that's right in front of us. And these other things they move from the must-do list to the should-do list. And I worry the things on the should-do list have moved to the nice-to-do list. I think that's part of the paradigm that's been flipped around investments in preventative care and primary care and mental health.
Thank you very much, and thanks in particular, I think, for connecting the community health needs assessment, which is just what it sounds like, a process that charitable hospitals certainly go through at least once every 3 years, and is a form of health planning and responding to community needs. And sort of the other end of the spectrum from that global health planning that is aspirational. Bringing it down to a different level of thinking about public policy interventions, Dr. Yeats, I wanted to ask you a little bit more about prior authorization. You referenced the importance of prior authorization in helping make sure that a patient gets to the right level, to the evidence-based next level of care, as opposed to what we all can understand might be the level that we wish that our loved one were appropriate for. And yet, it's pretty common, I think, for clinicians and administrators to cite prior authorization as one of the reasons why patients get stuck waiting for that next level. And I'm wondering if you could speak to, you've also spoken about changes that Blue Cross has made in the use of prior auth. Could you comment on public policy proposals to standardize or maybe even automate prior authorization, and on whether there's any value in having plans maintain a proprietary, distinctive approach to prior authorization coverage?
Yeah, so let me get at this from a couple of perspectives. So when I first started as the assistant chief of emergency medicine at the ID Milton, the first major project I was tasked with was implementing an electronic health record for the emergency department. So that transition, believe it or not, from paper to electronics. That was 2010, by the way. We were still using pagers and fax machines. Several years into my role as chief medical officer, I finally got rid of the pagers. We're still in healthcare, though, on the insurance side and the delivery side using faxes. And I say that because one of the next big initiatives that I was involved with prior to leaving the hospital was the implementation of an electronic health record for the entire hospital that was integrated with the other other Beth Israel Deaconess community hospitals, right? And within that electronic health record, we built in physician order entries, that physicians are entering their orders electronically and not by hand, but we also built in clinical decision support. Clinical decision support is nothing more than codifying the evidence, the best way we know to deliver care today, which is one mechanism of minimizing waste in the system. Right? So I would be held accountable in that system as a doctor if I was to go and order an MRI at the back. I would be flagged. Well, you haven't tried an anti-inflammatory. Your patient hasn't been through 6 or 8 weeks of physical therapy. Are you sure you really want to do this test, right? And I think for a lot of situations, that prompt is enough to cause somebody who, I think all of the providers are trying to do the right thing, to sort of rethink this. But I bring you back to that difficult conversation around preference-based care and the demand of the patients. They read about this in the news. They've seen about this online. They want the MRI. They want to know whether they've got the herniated disc that could help them have the surgery tomorrow. These are some of the things that we struggle with. That clinical decision support and those rules, I don't see them as being all that different from the medical policies that I oversee at Blue Cross Blue Shield. It's just I'm enforcing them at a different step in the process. And you could argue that I'm enforcing them downstream because of the risk that they haven't been applied upstream, that preference-based care is being delivered and not evidence-based care. The Health Policy Commission, the Commonwealth, is trying to hold that cost curve, that expense we're not trying to reduce the cost of medical care. We're trying to curb the rate of growth of medical care to single digits, 2, 3. We'll be lucky if it's under 4%, right? But these are the controls that put those little tweaks in place. When you look at systems where they refer to it as gold carding, where the prior authorization just is not applied in the radiology space, I've seen 10% increase in the utilization of these high-tech radiology, high-cost services compared to when the prior authorization controls were there. So the question is not whether it needs to be there, but are there opportunities to do this smarter? And I think this is where we're, I think from an enterprise technology perspective, we're behind in healthcare. It's extremely expensive. It's one of the first things that gets cut because we need to focus the scant dollars that we do have on actual direct patient care services and care delivery. We did a pilot at Blue Cross with one of our specialty hospitals here in Boston, and another company that was specialized in this tech space, where we applied the clinical decision criteria, by clinical decision support of the health plan's prior authorization criteria directly in the electronic health record of that hospital, so that when the provider went in there to make the order for the joint surgery, they got an immediate response of whether the criteria were met to move ahead with joint surgery, right? So there was like a crawler that went out into the electronic health record. It's like, yep, physical therapy, yep, ibuprofen, yep, an x-ray that shows advanced osteoarthritis. Bump that up against the clinical decision support, and if those criteria were met, gave them an answer immediately. And some of this was shocking. They reduced the turnaround time from an average of 10 days to 1.4 days on the cases where the criteria were not met. Those cases where it was not met would still get bumped to the plan to adjudicate. And in some situations, right, there are individual circumstances where it may be appropriate, and some of those were approved, and some of them were denied. The impact of the prior authorization on preventing the unnecessary, ineffective, or inefficient care. But reducing that from 10 to 1.4 days was significant. It's not actually the most significant, from my perspective, outcome of that trial. What we saw was 41% of the cases that providers were asking for prior auth on, we don't require prior auth for it. Imagine all of the inefficiency and waste, right? The people on phones and entering things in records, because they've sort of batched their process to just ask for permission on everything because they can't keep track of what actually needs permission on. That was a huge saving of resources for that institution. And that automation on the back end within the plan allowed us to do the processing at 83% of the cases where a human didn't have to touch them. I have positions within the organization that is defined as a fax splitter. They're literally people that split when a fax comes in with 1,000 pages, because it's got 83 different patients on it, they have to manually split the pieces of paper. So there's lots of opportunity in this space. There's a tremendous promise with AI. What we've done as a plan with the vast majority of our large teaching hospitals is they've granted us access, read-only access to the electronic health record, and we've said to them, don't even send us the clinical information, just tell us what it is that you want to do. We'll go in, we'll see if the criteria are met, and if the criteria are there, we'll give you the approval. Ironically, they're still sending us the information because that's their process, and they program their electronic health records to do this every 3 days if they haven't got an answer back within 3 days, which is just increasing the number of faxes and calls, and it's just, again, adding all of this burden to an already stressed system. So lots of opportunities there, I think, and we'd love to partner with institutions to do that.
Well, that's fantastic, and it sounds to me like a real bright spot in this discussion, that there is a real hope for, and I don't want to put words in your mouth, but I think what I heard you say is that if prior authorization is really based on trying to institute evidence-based medicine as opposed to preference-based medicine, then the evidence should be the same for all of us, irrespective of what payer we have, and that it should be the same as the clinical decision support information that is feeding into the EHR to help the doctor at the bedside, so to speak. So collapsing all of that into sort of one giant AI tool that will, through the wonders of engineering appear, that is great. I do think that it's possible, not that there's anyone cynical about healthcare here today, but it's possible that we might see some business pressure back against that kind of collaboration, because I do think there might be some differing views about the opportunities for, let's say, maximizing the extent of the premium dollar that could be minimized through this standardization. But I think it's a great topic to pursue from a policy perspective. So thank you.
And again, we're not trying to solve world hunger here, right? We're trying to get to that 85% efficiency, and I think we could get way better than that with something like this. I think though, not everything is going to be able to be automated. Some of this tip of the spear, precision medicine, expedited FDA approvals where the evidence is lacking and may actually turn out not to be there. We'll still have to have some individual consideration and human touch on those things, but at least we're applying the human touch in the areas where it's most effective, and automating those pieces where it does not need to be there.
Great, thank you. I think it's time to shift to some questions from the folks that are still with us. I know we've lost a few. Yes, first one, that's on.
Hi, my name is Christopher Robertson. I teach health law at Boston University. Thanks for opening your doors. I wanted to ask whether you see much potential already happening for telemedicine and artificial intelligence to not just adjudicate claims or prior authorizations, but actually provide clinical care, or actually out-clinic care before someone even shows up as a way to divert some of the food traffic that's considered using, including perhaps supporting paramedics to give higher levels of care through telemedicine.
So I think Amy spoke to that a little bit earlier, and maybe she'll reiterate some of her comments, but from the community health center perspective, again, upstream, before you get a decision to go to the emergency room, we've seen after the Carney closure a 20% spike in our utilization of urgent care services at our health center. And with that, I ran to my team and I said, what do you want to do? You guys are here, you know better than anyone what you want to try. And there was some talk and some efforts around triaging, but what we really came down to was actually utilization of something that we're doing now, rolling it out after a pilot called urgent telehealth. And so the scenario being that a person calls or shows up and is given the option of, you can be seen today, we'll squeeze you in, but we can see you actually right away, like literally switch you to a clinician now, a nurse practitioner or a physician, to do a telehealth visit. And we make sure that it's appropriate for that, right? We're not trying to get things that need to be sutured or something like that done by telehealth. But it's actually going quite well. We're seeing the ability to, in fact, we have to now staff even more to divert some of that demand off of in-person. The nice thing about telehealth is that you can actually get through those visits a lot quicker, right? And so your throughput is higher. Plus you're unburdening the staff that's there physically so that they don't get burned out as much. The other area where this is huge is behavioral health. Being able to do telebehavioral health, which started long before the pandemic. I was actually a consultant working with a company that was a major pharmaceutical company with a very innovative mindset, wanting to do telebehavioral health, telecognitive behavioral therapy at the time. And it works. The data are very clear that you can do this. You can have an effective counseling longitudinally or episodically with telebehavioral health. So we're leaning quite heavily into that. We think that that's actually going to be a great way to relieve some of the demand.
I'll jump in there from the behavioral health piece on that. So, I can't take out your appendix by telehealth, no matter how hard I try, but some specialties, right, really do lend themselves to this, and behavioral health is one of them. We're seeing, so since the pandemic, we are now spending as much on mental health services as an insurer as we are on primary care. Before we get excited about that, I'm not sure that that's necessarily a good thing, because I don't think we're spending nearly enough on primary care. But it is a reflection of how telehealth has facilitated access to care. And I think for many of the mental health providers that have been surveyed, telehealth went from being this thing that you purchased to nothing more than a medium by which to deliver care. So it went from being this benefit that an employer might add to their list of HR benefits to now we fund this as we would with any clinician delivering services anywhere. That has really created a dramatic improvement in access in the mental health space, and it's an area where I spend a lot of my time in clinical innovation within Blue Cross. We started off at the beginning of the pandemic with 17,000 mental health providers in our contracted network within the state. By the end of the pandemic, we were up to 20,000. In the last 3 years, with all of the innovation in this space and the fact that behavioral health lends itself to being delivered in this manner, I've added 65,000 mental health providers to our Blue Cross network. And this spans really two sets of innovators. There's the tech companies that are getting into mental health, and they tend to be much more enabled from the technology perspective, from the structured medical record, from focusing on objective evidence of improvement in mental health, things like measuring the PHQ-9 and GAD-7 depression and anxiety improvement scores. But they're also able to implement quality improvement initiatives within the practice because there's now a line of sight into these electronic health records that just didn't exist. You can sort of think of the divide in the house of medicine decades ago where there was medical and surgical and then mental health. Maybe they all started off with sort of craft-based, cottage-based industries, right? The primary care doctor who made the home visit when I was a small child is now in a community health center, part of a large system of care. But the mental health system sort of lagged behind that. We're still on sort of pocket schedulers and handwritten notes. Now we're starting to see that change. We're also seeing the clinicians who are trying to become more tech-enabled and more tech-savvy in that space. But by doing that, we've been able to contract with providers that are specialized in obsessive-compulsive disorders, PTSD, clinical services for our men and women in uniform that have unique care needs. And just, they refer to themselves as aggregators, just aggregators of many licensed independent clinical social workers, licensed mental health clinicians spread out all across the country in different time zones that have a Massachusetts license that can now deliver care sitting in California to somebody here in Massachusetts. But what does that mean? That means that at 8 o'clock at night here, it's 5 o'clock in California. You've got the ability to access services that traditionally had been, 9 to 5, 10 to 4, 10 to 4 3 days a week and home mornings on Wednesdays, however this had been. And so I think it was a tremendous opportunity.
And I know we want to move on to the next question, but just one more thought on this. This is the reason why I'm optimistic. Like, we're talking about the complexity of this problem, but there are scalable use cases out there that will help us solve this problem. In telehealth, thinking, we've described the ways in which we've used it since the pandemic, where we really rapidly innovated in a way that we never had before. And that is a scalable use case that we've only begun to scratch the surface on. Mobile integrated health is a scalable use case that we've only been able to scratch the surface on. And so there is a lot of hope on the horizon, and there's nothing like a good crisis to create alignment across all of the phases of the game and the ability to innovate. And I think that exists in a way that it never has before, that alignment and willingness to think creatively and innovate. So I'm excited about scaling these use cases that really will help to nip away at this problem in a meaningful way.
Before I take the next question, I just wanted to remind the panelists there's a robust community online that is watching as well. You also want to ask a question or many questions. So I'm going to ask for the short answers. I'm going to take one question here and then one from our online community.
Thank you very much for the service you all provide. My name is Jim Ricchetti. I teach tax law here. And I'm curious if you could comment about the trend towards for-profit hospitals putting aside their closures after they go bankrupt, stripping out all the assets. Let's assume that they are continuing to function as for-profits. What kind of impact is that having on your ability to function and service patients?
I don't know if there's a quick answer to that one. I guess I'll say something I've learned from very smart people, some of which are at this table, that we should be looking at all these entities the same, meaning that just someone's for-profit, non-profit status doesn't necessarily tell us how they're going to operate, how they're going to function in the healthcare market. And so I think we just need to think about that when we're thinking about the proliferation of for-profit medicine that we are seeing here in Massachusetts and across the country. I think I'm going to sort of maybe betray my my politics here and just say that I do think that there is a role for for-profit entities in the healthcare space, and they have the opportunity to bring innovation. There are examples of this in the behavioral health space where we have for-profit operators of mental health beds that would not be operated by the nonprofit system. We have examples of this in community health workers, really a really important part of the healthcare continuum, where for-profit oversight has allowed for the expansion of community health workers in very needed communities. So I do think there's an opportunity to leverage the for-profit model to improve care, to innovate, to rapidly iterate on what's working. That's what for-profit does well. And then transfer it into the nonprofit space to expand it beyond those for-profit entities. I might be alone in that answer.
Thank you to the panelists. My name is Amanda Teo. I'm the Executive Director for the Rappaport Center for Law and Public Policy. I'm aware that there is a class that's coming in right after this presentation, and so I invite everybody who wants to engage with our panelists to wait for them outside. I also know that there were a tremendous number of folks online and many questions. If you wanted to direct those to us offline using our Rappaport Center email address, we will get them to our panelists as well. When Jerry Rappaport envisioned this center, he saw its capacity to bring together practitioners, leaders in the community and in government, thought leaders, academics and students to have generative conversations around important public policy issues. There is no better instantiation of that vision than the panel that we had today. I am deeply, deeply grateful to all the panelists who I know were not just handling the crisis that we're discussing now, but about 50,000 other crises that are before them. So you're taking the time to engage with our community here at BC and also online is just tremendously appreciated. Thank you to all of you.